Everyone, is it like sharing the slide? Oh, okay. Hello everyone. So I'm a bit sorry for being late. There was a huge traffic. So my topic is the metabolic staging of non-small cell lung cancer. So the topics that will be reviewed here is very basic things, basics of FDG PET, how the imaging is done, and role of FDG PET in determining T, N, and M staging, available evidence, and pitfalls. So we'll see some images and some ancillary findings of it. So what is metabolic imaging? So we do the modality is PET, and the pharmaceutical is use FDG PET. So how it gets localized? It's a glucose. It's a marker for increased cellular glycolysis. That is, cancer cells demonstrate a Warburg effect where they show increased glycolytic pathway, anaerobic glycolytic pathway. So glucose as glucose gets localized, FDG also gets localized through the GLUT transporter. Then hexakinase acts upon it. So FDG becomes FDG 6-phosphate. So now it is a polar molecule and it cannot escape from the cell, and that's how it gets trapped. And most of these cells are also deficient in phosphatase enzymes. So it's a pretty irreversible step. So the activity we inject is 3.7 to 5.2 megabecquerel per kg. And after 45 to 60 minutes, we take a scan. So these are this is the patient preparation that we follow. And staging we all know, and I'll not go into detail. NCCN recommends PET-CT across all stages of lung cancer because PET-CT unearths at least 20% occult metastasis depending on the stage all over. So it is important. So regarding T staging, CCT is the imaging modality of choice, as we all know. And FDG PET performed along with contrast and CT. Then the integrated imaging study has similar accuracy as CT alone. And FDG PET-CT can accurately delineate the viable tumor from surrounding atelectasis. And so what I meant is this. So you can see there is a mass that is infiltrating left main bronchus, and there is surrounding atelectasis and collapse. So in the CT, it is not very well demarcated where the cancer actually stops. So, but with PET, it is very nicely seen. This kind of fusion scans are very easy for radiotherapy people for RT planning, because they can see the metabolically active volume of the disease where they can target it as their GTV. So this is another case where there is hilum is infiltrated and there is a huge area of consolidation and collapse, but the bulk of the tumor is small. So this is another where, so this is obviously a T4 stage, a T4 disease where there is a gross infiltration of mediastinum, but also you can see there is uptake in this vocal cord. So unilateral vocal cord uptake. So here by seeing this, this image only, you can say that recurrent laryngeal nerve will be involved, but many times this paramediastinal tumors might be very small, but you will see that unilateral vocal cord uptake, and the ipsilateral vocal cord will not show uptake, but the contralateral vocal cord will show uptake. So this implies that on left side there is vocal cord palsy, and on the right side there is compensatory uptake in the precoritinoid joint and also in the vocal folds. So regarding nodal staging, so morphological criteria for nodal staging is based on size. More than 1 centimeter in short axis is considered as significant. However, it is not enough because it has a very low PPV, around 50 to 56%. PET-CT has higher sensitivity and specificity than CT in staging mediastinal lymph nodes. So this study from 2006, it's a meta-analysis. So it showed that FDG PET-CT has a sensitivity specificity of 85% and specificity of 90%. However, that study also showed that PET-CT has a lower specificity as compared to CT in nodes greater than 1 centimeter. in short axis. So in conclusion, size and uptake, both should be taken into consideration. So we'll go a bit detail on the available literature because this is important for nodal staging. So there have been a lot of prospective trials. So I'll list few trials. I have listed a few trials here. So this is a busy slide, but what is important here is see the values. So we all know how you do nodal staging in CA lung. You do nodal staging, the gold standard is mediastinoscopy and biopsy. Or now we are also doing EBUS and TBNM. So if a non-invasive diagnostic modality has to be effective, it has to have a very high sensitivity for detecting occult nodal metastasis. So here you can see various sensitivity, specificity in this prospective studies. So it is barely approaching 90%. All are pretty low, even though they are higher than CT scan if you compare them, but they are still pretty low. So this has to be thought about. So this study is interesting where they saw that in clinically N2 disease by medianoscopy, they have FDG PET was initially negative, but 2.9% to and 3.7% cases they with medianoscopy, mediastinoscopy and endoscopic ultrasound they found disease. And if it is clinically N0, then they found like 17.6%, the 23.5% cases that basically this is false negative. So that we have to understand. And in terms of Indian scenario, so this study was done in our department, 391 patients retrospectively analyzed. And we also saw similar result. Sensitivity was 72% and PPV was also pretty low. So that is expected because in our population, infections and granulomatous diseases are high. So PPV will be low. But to summarize, higher sensitivity to CT scan alone, however, still lower sensitivity, and it cannot obviate the need of EBUS, TBNA, or mediastinoscopy. However, it may guide EBUS sites, like where you can take needle aspiration. So some imaging examples. So this is a tumor in right upper lobe, and you are seeing a subcarinal and right lower paratracheal node. So this is like a T2N2. So another tumor here, there is some consolidation. So this is also a T2, and you are seeing bilateral hilar and mediastinal nodes. So this is a N3 disease. So now coming to M staging. So incidence of distant metastasis in NSCLC varies from 18 to 36% depending on the staging and all. And the commonest site of distant metastasis are adrenal gland, bone, liver, brain. And PET has the ability to detect occult metastatic disease in approximately 29% of cases. So this is one prospective trial that I have quoted. So here they saw that in stage 1, 7.5% cases they found to have occult metastasis, while it increased to 24% in stage 3. So that is expected. So now we'll go through different sites of distant metastasis and how they may look. So adrenal metastasis, these are also pretty common, and FDG PET has a good sensitivity specificity for detecting adrenal metastasis, and it may also obviate the need for biopsy. So, but FDG uptake can sometimes rarely be seen in benign conditions like adrenal hyperplasia or even sometimes in secretory adenoma. So those things also be taken into account. However, in those kind of cases, the uptake is, the glands are normally diffusely enlarged, and the uptake is usually diffusely increased bilaterally, symmetrical in nature. And if it is an adenoma, secretory adenoma, and it is showing FDG uptake, the uptake more often will be lower than the liver background, or it will be pretty low, and it will not be more than the liver. So if we see this kind of uptake, then probability of the metastasis probably is low. So in our department, what we follow is very typical. So if we see adrenal nodule and if HU in NCCT is less than 10, then obviously this is lipid-containing adenoma. If the HU is more than 10, then either lipid-poor adenoma, metastasis, or any other pathology. Then we'll look at the FDG uptake. If it is focal intense FDG uptake unilaterally, then metastasis is more likely. If it is equivocal or negative, then and if there is no other distant mets, then we may consider, ask the clinician for biopsy. So I'll show you some imagings. So here, so you can see there is a adrenal nodule. It is not very big, but it is showing more uptake than the liver. And this was positive. This patient actually had gross metastatic disease, but I was just showing the adrenal lesion. So another nodule. So these nodules can be this small, but when you see in the MIP image or also in the PET image, many times in the fused images, it is very, sometimes it might be difficult to understand, but in the raw PET image, you can see that the uptake is definitely more than the liver. So bone metastasis, FDG PET is the best modality to detect occult skeletal metastasis. In this meta-analysis, they showed that FDG PET has a sensitivity of 92% and a decent specificity for detecting bone metastasis. So the main thing to remember about bone metastasis and FDG PET, that FDG PET can detect a lot of occult bone metastasis, and even in relatively early stage tumors, and it actually can change management. So this was a T2 tumor, but you can see, as you can see here, so there are these two marrow metastases. Here actually, if you see the CT also, you can see there is a marrow deposit. But the main thing is that when you, so this kind of lesions will be detected with MRI also, I assume. But when you are doing MRI, you will not do a whole body MRI. That is very difficult to do. So, but FDG with a single whole body imaging, it can detect this kind of occult metastasis very nicely. So pleural metastasis also, FDG has decent sensitivity and specificity. And even for pleural effusion also, the effusion itself may show increased FDG uptake. And few studies have also shown that that also has good sensitivity and positive predictive value in detecting malignant pleural effusions. So here also, so it sometimes in CT, if there is a mild pleural thickening, it may be a bit dicey whether to call it disease or it can be some benign or past fibrosis. But with FDG, many of those things may be solved. So here this is the NCCT PET. So this lung mass, and you can see there is pleural thickening metabolically active. This is the clear-cut obvious diffuse pleural thickening, FDG habit mass surrounding consolidatory area that is not showing uptake, and big pleural effusion. So now brain metastasis. Due to high physiological uptake, FDG is obviously not very sensitive in detecting brain metastasis. MRI is the investigation of choice. However, dedicated separate brain CT, if it is done during the FDG PET CT, we can detect a lot of metastasis, and in asymptomatic patient, the need for MRI may be obviated. So like this patient, so you can see there is barely any FDG uptake, but you can see enhancing lesion in enhancing solid lesion in CT. So in our department, we now take a separate brain along with MRI, and also TMH, they have now made it a protocol. They do MRI only when either if the patient is symptomatic for the brain metastasis or FDG PET is negative. Because with just asymptomatic brain metastasis, they will not give the patient brain-directed treatment. Restaging PET-CT is the best imaging technique for detection of recurrences and can differentiate recurrent disease and treatment changes efficiently. And if you are doing a FDG PET after the patient has received some kind of treatment, especially radical intent concurrent chemoradiation, then you should do it after 12 weeks to decrease the amount of inflammation that may be present. So here one example. So here you can see left hilar mass. So post the consolidatory collapsed area, and post treatment, it has completely gone. So, but on the other hand, this left side, there is a mass, and post radical CTRT, but it is still persisting, metabolically active disease still persisting. In this kind of cases, PET really helps. So now we'll go through quickly some pitfalls and some ancillary findings that we see in PET scan that may sometimes confuse and confound us. So this is you can see uptake here, but this is actually liver metastasis, but due to misregistration, you can see the uptake in lung. And consequently, this uptake, this was a lung nodule, but the uptake is seen in the liver because of the respiratory artifact. So many centers now do respiratory gating to ameliorate these things, but this is easy to understand. So this is a thing that we sometimes see. It is not very common, but we do see it often. So this is, we call it FDG embolus, but we don't know the actual reason for it. But one provisional, one hypothesis is that due to faulty injection technique, the FDG forms some kind of colloid, and that gets stuck into the pulmonary capillary bed, and you will not see anything in CT, but you will see a focus of increased FDG uptake. So if you see such a scan in a fused scan in PACS, you will get confused. But if you have to see the CT, and also you have to understand if the patient has been injected from that side. So if you inquire that, then you can solve it out. So as we know that FDG uptake is not very specific. So this is a very fine example. So this was a patient being evaluated for SPN. And so you can see this mass with liquefactive necrosis and surrounding consolidation. It came, so we had initially given it as malignancy, but it came out as organizing inflammation and negative for markers for malignancy. So this is a mediastinoscopy port. So this kind of thing, or like chest tube drain, those kind of things are also seen, that any places of inflammation that can be seen. So this is a very nice thing. So sometimes we see, because Warthin tumors also has association with smoking. So it has association with CL lung. So many times you will see that very nice, enhancing, well-defined parotid nodules that will be pretty avid, but this is not to confuse with metastasis. They will be Warthin's tumor more often. So illicit history of smoking in these patients. So this diffusely increased uptake noted throughout the skeletal system. So this was reactive marrow uptake. This patient had anemia. So these kind of things may be seen, but we shouldn't confuse them. And so there are few types of lung cancer that do not show significant FDG uptake. So I have one image here that is a typical carcinoid, may not show FDG uptake. You can see here, you can see diagnose it based on CT only. This is a endobronchial mass, deep, extremely enhancing without any FDG uptake. So this has to be a typical carcinoid. Another cancer is adenocarcinoma in situ or bronchoalveolar carcinoma, though they are also poorly FDG concentrating. So, but those also have like typical CT features, but they may sometimes be confused with infection or some other causes. So I don't have image of that. So some granulomatous infection. So this was initially thought of as a lung cancer, came out as TB. So here you can see tubercular granuloma in liver and also marrow lesion. So they were masquerading as metastasis. So this kind of pictures you see. So another thing, so this was squamous cell carcinoma. So these nodes were all given positive, but with the biopsy, the nodes came granulomatous inflammation. So these kind of things happen, especially in Indian scenario where TB may coexist with. So take home message is FDG PET scan is recommended for initial evaluation in all stages of NSCLC. Coupled with CCT, it is a one-stop shop investigation. And though FDG PET has overall higher diagnostic accuracy in detecting mediastinal nodal metastasis compared to CT, it is not high enough to solely rely on it. And it does not obviate the need for EBUS, GBNA, or mediastinoscopy. Investigation of choice to look for distant mets, it helps in detecting occult asymptomatic distant metastasis, thus changing management. And investigation of choice for assessing recurrence and treatment response, especially after radiotherapy. Thank you. Any question, I'll be happy to take. So it is a bit difficult because if you don't have access to all the images or raw data, it may be difficult. So you have to contact your radiology or nuclear medicine colleagues like that. So, but if the thing is that now, like misregistration, like when we see, so we are seeing uptake here, but you are seeing the nodule is here. So obviously that uptake should correspond, more likely will correspond to the nodule. Sometimes when we see the scan, before we have sent the patient, we may take another scan if we are having confusion. So there the will be registered. So most often this kind of misregistration happen supradiaphragmatic and subdiaphragmatic region due to respiratory artifacts. So many centers, what they do, they will do a respiratory gating. So with G machines, they have a software. So what they do, so they will take a mid inspiration scan with CT scan, and the PET scan that they take. So PET scan for a particular bed will last for a longer time than a CT scan, right? So they have to corroborate that PET finding. So they will take a mid inspiration CT scan, and they will, the PET scan registration, they will take the mediastinal bed, lung bed PET scan, they will take for a longer time. Say other beds are for 39 seconds or 40 seconds. So that lung bed, they may take for 1 minute, 2 minutes. Okay. So, and then they will summarize all the different inspiratory and expiratory cycles uptake, and they will kind of make an average, and that shows less misregistration. So these kind of things are available. Many places they do it. Anything else? Thank you.
Thank you, Dr. Syak, for explaining the role of nuclear medicine with such illustrative examples.